this is to some extent the second part of my presentation from this morning, in that, as I said, that was about really how do we do the best with what we've got at the moment, and think about all of the sort of aspects to caring for scleroderma. But what we really all want to do is to have more definitive treatments, and not just for the specific complications of the disease like digital ulcers or Raynaud's phenomenon or pulmonary hypertension, but we want treatments that really treat the overall disease, what might be called truly disease-modifying treatments. And this is not unreasonable, because in other areas of rheumatology and medicine we do have these treatments. So what I wanted to do was to just share with you some of the ongoing and recent clinical trials, because one of the things that I think has been really exciting in working in systemic sclerosis and doing research is that we have really moved to a time when there are now quite a lot of clinical trials going on, and this reflects increased opportunities and increased options for drugs that we might test, but also a much better understanding about how to do trials in systemic sclerosis that will help to understand the disease. So I'm going to frame the challenge that we have, though, as a reminder that systemic sclerosis or scleroderma is a really complex disease, and it's been a recurring theme through the talks today. And before we can really, I think, effectively treat the disease, we do to some extent have to understand the mechanisms that are going wrong in scleroderma. That's not to mean that we need to understand the cause of the disease, but one of the things I would say is that over the last 20 years, we've got a much better understanding of what's called the pathogenesis or pathobiology, the processes that have gone wrong in scleroderma that lead to the clinical problems that patients have. And we know that it's a disease that links abnormalities in the immune system, such as the autoantibodies that you've already heard about today, the blood vessels, including the small blood vessels around the fingernails, which is just really a window onto the small blood vessels in scleroderma that can be damaged, and the larger blood vessels in the kidney and in the lung that can be damaged. And then we know that scleroderma is a fibrotic disease. It causes scarring in the skin and the lungs especially, but also in other structures. So I think we understand enough now to think about how those different processes link together. We may not even always know what comes first, because we know that these processes are all interrelated, that the immune abnormalities can cause inflammation and damage to blood vessels, that the blood vessels can damage and cause scarring in the vital organs. But once we understand the sort of principles of the disease, we can really apply a lot of what is understood about biology to try and work out what are the sort of fundamental things that might have gone wrong when scleroderma develops. And the reason I'm showing you this is because to try and get better treatments for scleroderma, we're really trying to target the processes that have gone wrong, not just in one organ, but perhaps across multiple organs. So this is a summary table that just highlights, and it's really work that's come out of the last 20 years from lots and lots of laboratories and groups researching scleroderma around the world. But it has sort of identified the things that, if you like, might have gone wrong in scleroderma. We might have abnormalities in some of the proteins that are involved in regulating blood vessels, for example, like endothelin or some lipid mediators. So we can have abnormalities in the sort of proteins that regulate blood vessels and other cell types, like inflammatory cells, and you see the cannabinoids here. This is the stimulation of the cannabinoid receptors. We know that it's an autoimmune disease, so it's not surprising that there are abnormalities in the cells of the white blood cells, the cells of the immune system. There are abnormalities in the proteins that are produced by cells that are responsible for the way that they communicate to each other, and these are sometimes called cytokines or growth factors. And you can see these are all sort of given code names, if you like. Interleukin are the drugs that come from, the proteins that come from the immune system, and you can see they're all different letters. So the very first interleukin that was found was interleukin-1, but it didn't stop there, and we're now into the high 30s in terms of interleukins. But you can see here IL-17, IL-31, all may be relevant. And what we've also learned about is that scleroderma is, to some extent, a disease in which there's abnormal tissue repair. So there are these immune and inflammatory changes that occur, but then it damages the tissue. But what seems to be particularly a problem in scleroderma is the tissues don't repair properly. Instead of that, they form scar tissue. And so the pathways that we know now are very important in normal connective tissue growth and repair, which have all come out of studies really of embryology and of how, how tissues develop during normal growth and development. Those can also clearly be abnormal in a disease like scleroderma. So once you've come up with these sort of color-coded processes that could be abnormal in the disease, what's very exciting is that in the modern era, even just by looking at other disease areas, we can find that we've already got drugs available that start to target some of these specific proteins and pathways. So we've got drugs that stimulate the cannabinoid receptors, we've got drugs that target the immune system and the cytokines that I've just talked about, and even these pathways that are important in growth and development of and repair of connective tissue. So what I'm going to go over really in the next few slides is to think about how this has been translated into clinical trials. And I did want to re-emphasize that one of the things I think that's made a lot of progress, and you'll see that, and that's why I've divided my talk into, if you like, the past and the future, is that in the past we were not only testing the drugs, but we were also trying to learn about how to best do the clinical trials to get the best evidence so that we could support getting drugs approved, but in particular, of course, getting drugs funded and available for patients. So I'm going to talk a little bit about immunosuppressive treatments, because you've already heard, and I've shown you the guidelines that we already say that and appreciate that patients with some forms of scleroderma should all really be considered for immunosuppression and some of the drugs that we use. I'm going to share a little bit of experience about some of the learning that we've had in terms of doing trials of drugs that might have real potential, but where the trial itself didn't really give us the answer. And that, as we heard from Professor Black earlier in the morning, it's very important because sometimes when something doesn't work, you can learn just as much from that from a scientific point of view as when it does work, and it can be used sort of for the next step forward. So then I'm going to talk about the future, and really the future are trials that are really ongoing or just about to report the results. And I think some of them are very exciting, and I will just give you a very brief preview of some of the results that are emerging. So to come back to the immune suppression, so this really is something that we've known for quite a long time. We know that early in scleroderma you get a lot of activation of the immune cells, particularly around the blood vessels in the skin, and you can see that here. And so it makes logical sense that if you suppress the immune system, and we've got many ways of doing that that have come from transplant medicine or from other types of immunological therapy, that you could perhaps improve outcomes. And so this has been the logic, and we've been very familiar in rheumatology with doing that, because a lot of the diseases that we deal with, like vasculitis and arthritis, can respond well to immune suppression. So we have a range of drugs that we use for treatment, and you'll see the names, and they're maybe quite familiar: methotrexate, cyclophosphamide, azathioprine, mycophenolate mofetil, or MMF. These are all broad-spectrum drugs that are used in other forms of rheumatic disease, but logically might be helpful in scleroderma. There's a sort of, if you like, a nuclear option, which is very high-intensity immune suppression with a stem cell rescue, and I'll specifically come back to that in a minute. It's been very hard to do really good trials of these standard drugs in scleroderma, and one of the reasons for that is that they are standard drugs. They're available, and we are fairly confident that they're helpful, but it's very difficult, therefore, to deny a patient a treatment that you think is going to benefit them, but that does make it difficult to get strong evidence supporting their benefit. So the way that we have approached that in the UK has been to do observational trials, and Professor Herrick and I have worked closely together on some of these studies, and we did a UK observational study which was partly supported by the patient organisations, and we've recently completed a European observational study, again partly supported by SRUK, but also with major support from EULAR, from the European Rheumatology Organisation. And here are the sort of top-line results of this observational study. So in an observational study, you don't randomly allocate patients, you just use the drugs that are available, but you standardize the way they're used. And what we had an important group of patients who didn't go on to immune suppressive therapy. And what you can see here is the average change in the skin thickness score for scleroderma patients over 12 months of therapy. And And these are very cleverly modelled changes that take into account all of the baseline factors that might have influenced outcomes. So it's the closest we can get to a clinical trial. And what you can see, at least at this group level, is that patients on MMF or mycophenolate MMF or methotrexate certainly showed improvement, a significant improvement in their skin score at a group level in the patients, more than 100 patients treated with MMF. Those that were on no treatment, in fact, didn't do so well, but more importantly, and obviously we looked carefully at the long-term outcome, these patients didn't do very well overall either, and in fact there was a significantly worse survival in these patients, even over the 2 years of the follow-up of the study. So it's not that they have mild disease, and we seem to be improving outcomes with this treatment. So that's the skin, but we also use immune suppression for the lung, and we have slightly better evidence for the lung. And here is the data that came from, again, looking into the past. 10 years ago, we completed the FAST trial, which is a fibrosing alveolitis in scleroderma, that tested whether cyclophosphamide, a chemotherapy immune suppressant followed by azathioprine, was helpful in scleroderma lung fibrosis. And what you can see, again, in this study, we were able to do a proper placebo-controlled trial, and you can see that if you went on to active treatment, there seemed to be, on average, improvement in your lung function over 12 months. If you were on placebo, there was decline. This decline was relatively modest. It was about a 5% decline in lung function over the 12 months. But it was certainly important support to suggest that we're doing benefit with treatment, and potentially if you don't have treatment, you may not do so well. So in America, they've had better funded, larger studies, and they've done studies called the scleroderma lung studies, and they did a study that really confirmed what I showed you with the intravenous cyclophosphamide, but they used oral cyclophosphamide, a slightly more toxic but perhaps more powerful approach. And they showed the same results, really. And then, so the second stage has been to really confirm whether you could get the same benefit from MMF as you get from cyclophosphamide. And here are the results of the second scleroderma lung trial, the SLS2, which really do show that for quite a number of patients, you can see significant improvement. So this is the percentage improvement in your lung function over, in fact, in this case, over 2 years. And what you can see is that a significant number of patients, either on cyclophosphamide or on MMF, have this more than 10% improvement, so a really important improvement in their lung function over 2 years. And you can see slightly more patients have this improvement on MMF. So it's certainly not a drug that's not as good as cyclophosphamide. It's definitely safer and better. And so this was a very useful trial. And in fact, the trial could also give information about the benefit for skin by comparing the placebo patients to the active treatment patients, which supported what I showed you with the observational study. So we think that those low-level immune suppressive drugs are helpful, and we've got the trial evidence from the past to support that, but we also know these are not cures, so they're just a starting point, if you like, for what we need to achieve. But the logic was that if small amounts of immune suppression are helpful, maybe very large amounts of immune suppression will be even more helpful, and this was the rationale for the stem cell transplant programs. So stem cell transplant involves giving extremely high doses of chemotherapy to really wipe out the immune system completely, to such an extent that you wouldn't survive this procedure if you didn't then have a rescue of your own stem cells. So your stem cells are harvested from the peripheral blood before the treatment, then you have this treatment, and to allow you to survive that, you have your stem cells put back. That might sound very intensive, and it certainly is, and unfortunately, even in the clinical trials, quite a lot of patients died from this treatment without having the chance to get any long-term benefit. But if you survived that treatment, you did seem to get benefit, and there have in fact been 3 clinical trials now, the largest being the European ASTIS trial, where half of the patients had cyclophosphamide, and I've already shown you has some benefit, and half the patients had a stem cell transplant. A slightly smaller study was published just earlier this year, which was the North American study, the SCOT trial, which had a particular focus on patients with lung fibrosis, but again treated the patients overall. And what you can see, the results really were very similar to what we'd seen in the European study, that there is long-term, this is the survival of patients without getting a major organ-based complication. And you can see that if you have the stem cell transplant, you do seem to do better than if you don't, just have the standard treatment. But important point I'd point out is that even in this study, and that was the same as in the ASTIS trial, it's only after 2 years that you really see the benefit. So up to that point, you know, you actually could argue you were better off being in the control arm of the study, but long term it does seem to be helpful. But it's clearly not a treatment for everyone, and so one of the things that we've really wanted to try and do is to get the sort of benefit that you get from a stem cell transplant without the sort of intensity of the immune suppression. So one of the ways you can try and do this is by a more targeted approach to the immune suppression. So our group, working with the Brompton Hospital and others around Europe and in North America, shown that a drug called rituximab that you heard from Professor Bruce as a treatment for lupus does also seem to be quite helpful in some patients with scleroderma, particularly with lung fibrosis. And it seems to be particularly helpful if you haven't responded to the cyclophosphamide and MMF treatments that I've just shown you in the previous slides. And how we know that this drug seems to work is that if you look at these patients that we published in a collaboration with the Brompton Hospital, you can see the lung function was declining despite treatment, and then when the patients had rituximab, it definitely in most cases improved. So we know that this is a treatment that could be helpful. What we don't know, of course, is whether it only really works in patients after you've failed other treatments, i.e. it's a sort of treatment that targets the pathways that the standard treatments don't work very well on, or would it perhaps be something we could use earlier on in the disease? And so this is the first ongoing trial that I just want to discuss or mention, and that's the Recital trial. So this is the only trial, I think, that's going on internationally now to really test whether rituximab, this drug that's now accepted and funded as a treatment for vasculitis and for lupus and for rheumatoid arthritis, might also be a drug to consider in scleroderma and lung fibrosis. So this trial is being led from the Brompton Hospital by Professor Toby Mayer, and all the major scleroderma centres around the UK are participating in it. And so we've all put patients into this study, which is essentially asking whether as an early therapy, you'd be better off giving rituximab compared to cyclophosphamide, the sort of chemotherapy treatment that I showed you. So it's comparing rituximab and cyclophosphamide, particularly over 6 months treatment, to see whether you get a good initial response. If this trial is positive, I think it would be very likely we could then get approval to use rituximab as a much earlier therapy in scleroderma lung fibrosis, so that would be very positive. That trial is ongoing. It's aiming to recruit more than 100 patients. I think around 80 patients are already recruited, so it's sort of well over 2/3 to recruitment, and we hope that we'll get the results that of that study in due course. So again, I highlighted that we have to learn from our lessons of the past, and from that slide I showed you of all the pathways you might like to try and block in scleroderma. One of the pathways that would be particularly attractive to block is a pathway called the TGFbeta pathway, because TGFbeta seems to be a very important factor in causing scarring and fibrosis. So we did a while ago, in fact 10 years ago, we did the first trial of a drug that blocked TGFbeta, and this was the CAT192 trial testing a drug called metelimumab. We learned a lot from this study, and unfortunately what we didn't learn that was blocking TGFbeta in this way was a highly effective therapy. We got perhaps a hint that there might be a benefit because the patients on the higher dose did slightly better than those on the lower dose of the drug. But in fact, overall, the patients didn't do significantly better than those patients who didn't have any active treatment at all. But we learned from this study that you really need to think very carefully about which patients go into a trial, what stage of trial you're treating. But the thing we learned most is that you need to have a drug that is biologically effective, because this drug just blocked one form of TGF-beta, and in fact there are two forms, and we've subsequently shown that the two forms act together, and if you just block one of them, you're very unlikely to see a good treatment effect. So that's something that we've learned from, and we can move forward with, perhaps with other trials, to block TGF-beta in the future. So I'd like to move into the future now. and was just being held back a little bit there. So what I've covered really is I wanted just to sort of highlight the evidence base for the drugs we're using now, showing you really these are not cures, but they are drugs that do have evidence to support them. But I want to just talk about some trials that are ongoing and then just finish with just some very top-level insight into the emerging data from some of those studies. So, I've moved too fast into the future. Let's go back. If I can go back one more. Okay, so the first thing, so if you remember back to that first slide that showed the different pathways, we know that certain signaling pathways in cells are very important in tissue repair, and one of those are a series of enzymes in cells called tyrosine kinases. Now, there's a drug that blocks these enzymes that are important in tissue repair, and this drug is called nintedanib, and it's been shown to work in idiopathic lung fibrosis, so in a disease that isn't scleroderma but has lung fibrosis as a major part of the condition. So the fact that this drug works in lung fibrosis, and it's also helpful in some forms of cancer, really led to the suggestion that it might also be helpful in scleroderma, and there was very strong laboratory evidence to support that. And on that basis, because it's a drug that's already available, a trial was designed, and this is very important because this is the census trial. This is the largest clinical trial that's ever been undertaken in systemic sclerosis, and it's fully recruited now. And in fact, at the end of this year, probably early next year, we will get the results of this study. So we don't have results yet, but we know this trial is fully recruited. More than 500 patients have been randomized to either receive this drug, nintedanib, or placebo, so half receive each. But most importantly, it allows patients to have those standard drugs that I talked about, like MMF. So we will know not only whether this drug works, but whether it works better, perhaps, if you combine it with those standard therapies. So it's very exciting to think about this hopefully being a landmark study, but we won't get the results till early next year. And so perhaps by the conference next year, we'll be able to at least report on the results of that. I can have the next slide. So you mentioned, I mentioned twice, I think, the cannabinoid receptors, and cannabinoid receptors are what cannabis binds to, but cannabinoids actually are natural substances that the body produces. There are two cannabinoid receptors. There are receptors in the brain that are responsible for the sort of psychotropic effects of cannabis, but there are also receptors on the immune cells and fibroblasts. These receptors, which are called CB2 receptors, seem to be very important in the resolution of fibrosis. So that's very interesting because a lot of the drugs that we have may switch off fibrosis, but they won't necessarily stimulate it to resolve. And we know that it can resolve with time, and that's obviously part of normal wound repair. So it's quite exciting that there now are drugs that selectively block this, or selectively stimulate this CB2 cannabinoid receptor, because it allows us to have the sort of therapeutic benefits without the side effects of cannabis. And again, this drug has gone through its first initial trial phase, and it's now actually into what's called the phase 3 trial, a definitive trial, to see whether it might be something that's going to be helpful. So the first study was quite a short-term study, but did look to be quite positive. And I'll show you here, because the patients that went on, even on this short-term study, which was just over 16 weeks, so just a 4-month trial, that went on to the cannabinoid agonist, which is now called Lennabasem, that they did much better. They showed a global improvement in the scores for their scleroderma severity compared to patients that were on the placebo. And again, like the census trial of nintedanib, this is a drug that was added onto standard treatment. So all of these patients were on MMF for their diffuse scleroderma, and they had this drug added. And even over 4 months, you can see this is remarkably positive data. Now, for good reason, health authorities always want to see at least 2 clinical trials to confirm a result like this. And so the second trial that's now ongoing, that will recruit, again, more than 300 patients, looking at 2 different doses of this cannabinoid, will be very helpful to telling us whether this is superior to placebo, and in particular whether it works well in combination with other drugs. But I think it's one of the most exciting trials that's ongoing at the moment because it's a very safe tablet. There were no real toxicity findings, and it's very easy to take, and it's very well tolerated. It's a tablet, so it doesn't require injections to get the benefit. So we will see. Thinking about trying to stimulate pathways that might be helpful is a very positive way, I think, of trying to tackle a disease like scleroderma. And there are pathways in cells that are very important in normal resolution of inflammation and repair. And a number of these are the PPAR pathways. So there's a drug that stimulates this, and these drugs were initially shown to be quite helpful in diabetes, but the initial drugs did have some toxicity, but now newer drugs that have a different profile of stimulating these receptors seem to look much safer. And again, there's a trial ongoing at the moment of this drug called lanifibranor, which stimulates these pathways, and which, again, we'll get the results early next year as to whether this drug is superior to placebo in a clinical trial. So the FAST trial, as I say, this is a slightly smaller study, 132 patients, but comparing 2 doses, again, of this lanifibranor compared to placebo. And at the conference in Chicago next week, we will be presenting some of our data where we've tested this in some of the preclinical models of scleroderma, so in the laboratory, and it's certainly looking very promising as a potential treatment. So we'll wait and see whether the clinical trial is positive. But again, I think what we're confident about is the trials that are done now are much more likely to give a conclusive positive signal if the drug works than perhaps when we were doing studies such as the anti-TGFbeta trial that I showed you, largely because we now have enough patients and we have selected the patients carefully enough to be sure that we get an interpretable result. Okay. Can I go back one slide? Okay. So another drug that we're testing at the moment is a drug called Riociguat. Can I go back one more slide? Is that possible? Here we are. So Riociguat, I talked about pulmonary hypertension, and what was very interesting is that one of the drugs that's licensed for pulmonary hypertension is called Riociguat, that stimulates, again, there's a theme here that we're quite interested in drugs that stimulate pathways rather than just block them, because stimulating the pathways that might help fibrosis to resolve is a very attractive approach to treatment. So stimulating the pathways that are helpful in pulmonary hypertension, and this drug Riociguat is licensed now and effective in scleroderma pulmonary hypertension. But in fact, again, it looks to be quite a potentially effective drug for fibrosis as well as for the vascular damage. And so a trial called the RISE trial is testing whether this drug might specifically be effective in early stage scleroderma, looking at skin fibrosis. So I'm going to show you, I'll show you just some of the results that are going to be presented just at the end of the talk. But Professor Black mentioned in her talk the interest around interleukin-6. So one of those proteins produced by the immune cells that could be driving fibrosis in scleroderma. So I've shown you some details about pathways that we might stimulate that could be beneficial, but of course if we could block the drivers for fibrosis, that would also be very attractive. So Funong, who spoke in the previous session, and I worked a few years ago on IL-6 in scleroderma, and we were very struck by the fact that patients who had severe scleroderma often had high levels of IL-6 in their blood. And we also worked with the Brompton Hospital and showed that those patients who had high levels of IL-6, not only did they have very bad skin fibrosis, but they also had a tendency to have worse lung fibrosis. And so we thought that IL-6 might be a very good candidate to block in treating scleroderma, and we were enthusiastic about this because IL-6 is already something that is blocked to treat rheumatoid arthritis. So we have drugs available that block the IL-6 pathway. So on that basis, we applied for funding from Arthritis Research UK, and they were quite positive about the possibility. But we then also approached the manufacturer of the drug tocilizumab to see if you could give me the next slide. Roche, to see whether they might actually be interested in helping. And in fact, they liked and were persuaded by the idea, and they invested in quite a large clinical trial of 86 patients, where they, again, received either placebo or active treatment. And you can see here the effect on skin disease. The red line is the patients who are on the active drug, the tocilizumab, and you can see that the skin certainly improved over a year, significantly more in that situation than those patients who'd received the placebo arm. If you could press, I can try. Oh, thank you. We also showed that the skin fibrosis signature improved, which was important. So it seems like we were really having an antifibrotic effect. And most importantly, we showed that patients were much less likely to get progression of their early lung fibrosis if they received tocilizumab. And this was very important because this is the first time ever that we've really showed the ability to prevent lung fibrosis in early diffuse scleroderma. So you can see here that about a fifth of patients on the placebo developed progressive fibrosis, and only less than 1 in 20, less than 5% in the active treatment, even over a short period of time. So that trial was encouraging, and it led to the second trial, which was much larger. It was, again, to look at the effect on skin and lung and see whether this might be a helpful treatment. And related to IL-6, so IL-6 in fact is a family of proteins, and there's another protein called Honkastatin, which is a member of the same family that also looks like it could be very important in fibrosis. And so in addition to the trials blocking IL-6, there are trials ongoing at the moment blocking this protein Honkastatin M. I talked about the immune system, and I just wanted to mention one other trial, which is the ASSET trial, which targets a very specific part of the immune system, the way that the immune cells talk to each other and stimulate each other in scleroderma and autoimmunity. And again, the ASSET trial is testing a drug called abatacept, which is available and used for treatment of rheumatoid arthritis, and again, has shown potential in a small study, and so a larger study has just recently been completed. So what I've given you, I think, is a sort of feeling of how we used to do trials and how we've sort of understood the disease better and made, I think, sensible choices about which of the available drugs to test to see whether they might work in scleroderma and be safe and effective. But once we do the trials, we obviously then very patiently wait for the results. Now, I thought we would have to wait a little bit longer because at least for 3 of those trials, the results will be presented at the conference, for rheumatology conference in America in Chicago in about a week's time. But in fact, about a month before the conference, the abstracts of the results are all published online and are freely available. And so I think that it's not unreasonable just to share with you some of those data that are now publicly available in the abstracts. And what I've done is put together a table. And the point I wanted to make is that green is good, and we've reached a stage, I think, in scleroderma trials that we're seeing quite a lot of green in the table here. That doesn't mean that we've cracked the problem. In fact, far from it, because we've learned a lot from these trials about again, how we can do the trials in the most effective way. But I think what I'd just like to sort of highlight really is that we did show very clearly with the tocilizumab trial a very highly significant benefit for lung fibrosis again. So in a much larger study, we really, I think, the most robust trial ever that's shown that blocking IL-6 certainly seems to be helpful for the lung fibrosis. Interestingly, and as we might have thought, in fact, based on our original results, for the skin it's a bit less clear. It certainly helps patients who've got very bad skin, but as a global treatment for skin, it wasn't quite so impressive. So that's an important learning point. And likewise, for some of the other drugs, I showed you the Riociguat. Again, it was only a small study, and it almost showed a sort of overall benefit for skin, but not quite. But it did improve some of the other aspects of the disease. And the abatacept trial was very impressive because it showed some trends of benefit across the different disease areas, but particularly for the functional impact of scleroderma, the effect on joints and function, it was highly beneficial. And again, that's likely, I think, to move now into another clinical trial. So what I wanted to do to finish on really was just to say that we do have to manage our expectations in a complex disease like systemic sclerosis. We're definitely much better at doing clinical trials. It's very exciting that there are so many pharmaceutical companies as well as research organizations supporting good clinical trials in systemic sclerosis and in lung fibrosis and other complications, but we're also still on the learning curve about how we do the trials, because the trials are still, I would have to say, from those recent results, they're still not so unequivocally positive that we can say we've really stepped forward and got a disease-modifying treatment, but they really do start to show that the drugs are impacting on the disease, and so it's a sort of very good platform to move forward on. But I think we also realize that in a disease like scleroderma that's so complicated with so many things that could potentially go wrong, it's the more targeted the treatments we use, the more selective perhaps the benefit is going to be. And that really comes right back to what Professor Bruce said about lupus, the same sort of experience. So it's very likely with these more targeted therapies that even when we have treatments that we're confident work, they may only work well in a proportion of patients, and it may be then that we come back to this point of trying to be much more precise or in the way we choose patients and choose treatments for the future. So I will finish there, and very happy to take questions. Thank you.